Okay, well, good afternoon, everybody, and welcome to this webinar on the burden of disease assessment for COVID-19. My name is Jose Peñalvo, and I work at the Institute of Tropical Medicine in Antwerp, where we coordinate the European project unCoVer that focused on COVID-related data analysis. With me, I have Brecht de Bleshauer, from Science Nano in Brussels, which is also a partner in the unCoVer project, but he is also representing the cost action on the European burden of disease network. Next, please, Brett. Actually, many partners from unCoVer are also part of the cost action, the European burden of disease. unCoVer is a project that was sponsored last November with the title Unraveling Data for Rapid Evidence-Based Response to COVID-19. And this project is all about gathering data together coming from the mostly hospitals across Europe, but also internationally. So we are trying to put together real-world data to assess questions regarding COVID research. We are 29 partners from 18 different countries. Like I mentioned, most of the European most of the partners are also coming from the European Burden of Disease Network. We have 6 work packages from data identification, assessment of the ethics and data protection, data harmonization, and finally data analysis, dissemination, and coordination. Here you have the webpage and the Twitter handle in case you want to have more information, or you can always send an email to Brett or myself. Next, please, Brett. Maybe you can introduce the cost action.
Yeah, thanks, Jose. So this meeting is co-organized with our cost action, European Burden of Disease Network.
I'm not sure we can hear you.
Oh,
I hear you, Brecht.
Yeah, thanks, because I'm indeed not muted. So we are now close to 300 people, mainly from within Europe, but also individuals from outside of Europe who have an interest in burden of disease. And with our network, we are able to support capacity building activities such as these webinars and our training schools. And yeah, just provide a platform to get together to learn from each other's experiences and expertise. If you're not yet a member of our network, you can easily sign up via burdeneu.net, and you can also follow us on Twitter via the BurdenEU Twitter handle. Okay, well, thanks.
Great. So we have 3 great speakers today. They will be discussing about their findings on the assessment of the burden of disease in Germany and Scotland. And we will also have a lecture or a presentation providing insight into the also burdening situation with post-COVID conditions. So I introduce you first to Dr. Elena von der Lippe from the Robert Koch Institute of Germany. So we'll be talking about the disease burden of COVID-19 in Germany. Please, Elena, can you share your screen?
Thank you very much for this introduction. I'm going to talk about the burden of disease assessment for COVID in Germany. The work that has been done is from quite a big team at the Robert Koch Institute, and I have the pleasure to present our findings. So first, some few words for our project. Burden 2020 project started about 3 years ago, and it's a national burden of disease study for Germany, where we apply the global burden of disease methodology, but we try to use the best available data for Germany and estimate subnational indicators. And all this exercise helps us build capacity in Germany. So we are calculating YLS for the whole mortality envelope, and we have a choice of diseases for the YLDs and DALI assessments. And last year, in the course of the pandemic, it was decided to try to evaluate the burden of disease of COVID using the same methodology that we have established for our project. So this is the first part of the estimates, the years of life lost. And the databases for this are the number of deaths, daily records for the whole year through 2020. The curves, I guess, look similar in most of the countries. In the beginning of pandemic, Germany was doing quite well with relatively few cases of death, and at the end of the year it looked totally different. So we, in total, we had for this year a little bit more than 31,000 recorded deaths with SARS-CoV-2 infection. And for our estimates, we are making difference between died from and died with COVID. So in order not to overestimate the burden of disease, we concentrated only on the cases where it is for sure reported that the death has taken place because of the COVID infection. And this is about 82% of all the recorded deaths with COVID. We are using the German life tables and applying the maximum life expectancy observed on a federal state level. And it is the same for women and men. In total, we have about 90% of all the deaths happening at ages 70 and above. This is part of our results. I cannot show you too many results because of the time limitation, but in total, we had estimated more than 30,000 years of life lost, with men significantly more losing years than women. And this is maybe due to the middle age groups where we observe a very high level of men who have died prematurely. If we compare the share of the deaths and the share of the years of life lost, this is a picture that we would basically expect. For instance, for people younger, women younger than 70 years old, the share of deaths was only about 7% of all deaths from COVID. But in terms of years of life lost, these are almost 1/5. And even more in men, where about 15% of the deaths were observed in the younger age groups, but more than 1/3 of the years of life lost. On average, through all the age groups, we have estimated the years of life lost to be 9.6 in total per person. And this, if we have a look at the younger age groups, then definitely 29 years, a totally different number. So we also tried to compare somehow the deaths because of COVID to other mortality statistics that we have. We don't have up-to-date data, so we had to rely on the years, on the year 2017. And here I plotted the average numbers of causes of death for ischemic heart disease, lung cancer, stroke. These are the ones that have the highest number of cases. And here is the seasonal variation of the COVID in deaths. The red line tries to smooth a little bit the curve, and the blue line is the average per year. So if we compare it to the other averages, we can say that deaths due to COVID ranked 6 last year. But if we have a look at the seasonality, so we can also say that at the end of the year, the COVID deaths were the most important compared to other causes of death. However, one has to be very careful in interpreting these comparisons because the other causes of death may also have some seasonality, like for instance, lower respiratory infections, where usually the flu cases are recorded. But this is just a rough comparison. In terms of the years lived with disability, it is more challenging to perform some assessment. So there were a lot of assumptions and decisions that we had to do on the road. This is the data that we had, the non-fatal infections by age and sex. And in total, we had 1,700,000 records of non-fatal infections for year 2020. And we tried to make use of all the information that we had on reported symptoms and hospitalizations in order to be able to define the severity distributions. And we used existing disability weights and estimated our own durations of disease. This is the definitions that we used. So we oriented on the global burden of disease, lay descriptions for upper respiratory and lower respiratory infections. Because of the disease development of COVID, the first symptoms are more comparable to the upper respiratory infections and the later symptoms to the lower respiratory infections. So we defined the mild cases like symptoms with symptoms like having sore throat, rhinitis, impaired sense of smell or taste, or clinical symptoms present. The moderate cases additionally had reported to have fever, coughing, pneumonia, or diarrhea. And the hospitalization, the people who were hospitalized were defined as having a severe case and being in an intensive care unit was then defined to be the most severe or critical case. The disability weights, as I said, are coming from the global burden of disease mostly. So we have taken the mild case for upper respiratory infections, the moderate case for upper respiratory infections, and the severe cases for the lower respiratory infections. And for the intensive care unit, we are using the disability weight from the European Disability Weight Study. And this is how our severity distributions look like. We have about 42% people asymptomatic, 25% with mild cases, 27 moderate, 5% were hospitalized, and less than 1% were in intensive care unit. The other very important decisions that we had to make was the duration of each of these states. So we oriented on the standard 40 days definition, where usually it was reported that about 14 days people are infectious or they have to stay in quarantine and so on. So we applied this duration for asymptomatic, mild and moderate cases. And from our data, we had information on admission to the hospital and the date of exiting the hospital. So we could estimate an average duration in the hospital for the patients, and it was 21 days on average. So we decided to stay with this duration for the severe cases and the 32 days for the intensive care unit cases, which we could also read from our data. This is a part of our sensitivity analysis. As expected, the severity distribution is very much varying through each week of the year. So in the beginning of the pandemic, we had very few cases with asymptomatic description. Mostly were moderate or severe cases that were recorded. And in the course of the year, the share of the asymptomatic cases is increasing. This could be due to different reasons. One of them is the availability of the tests that was made, and this allowed to discover more asymptomatic cases than before. And I guess if we are here to prolong the weeks and go into year 2021, the share of these asymptomatic cases will continue to stay so high, or even maybe go higher. So this is just part of several further analysis that we did to check the sensibility of our data. All in total, compared to the years of life lost, we had definitely very much less years lost due to disability. In total, 2,000 years, equally distributed between men and women. And mostly they're coming from the middle-aged age groups. As to expect, contrary to the years of life lost, with the years lived with disability, the share of the infections is a little bit lower than the actual infections, because we have all those people that had no burden from COVID. The asymptomatic cases were yes, as a share, then we have less wildies than infections. And the final part, the DALIs, as expected, the DALIs are definitely composing mostly of years of life lost, within 99% having because of mortality. However, it is interesting to see that in the young age groups, this share is totally different, and the years lived with disability still play some kind of a role here. We were also able to make some regional estimates here. One example where we see that basically in terms of DALIs, the southern Germany had a higher burden of disease compared to northern Germany. So our study had a lot of strength, but also some limitations. So we were very happy to be able to apply the burden of disease tool to assess the burden of disease COVID. So we think that it is allowing for monitoring pandemics and shifting the focus from cases to severe impact cases, and somehow it is basically possible to make comparison to other diseases. We had some limitations, like the completeness of data. We had significantly a lot of missing values or missing information on symptoms. So we had to make many decisions on the road to be able to make this assessment. For the validity and reliability of the information that we have received at our institute, stays also a kind of problematic value with the data quality. But however, I think the biggest limitation for this assessment up to now is that we were not able to consider the effect of long COVID, which is definitely an issue. And but we are working on this, and we are trying to assess in the long run also the effect of long COVID on burden of disease because of COVID. And to make some advertisement for our article, we have published it in English and German, so you can download it, and we have very full appendix with methodological issues, and everything is described, all the decisions that we have taken. It is all written down, so please have a look. And I want also to make an advertisement for a project that has just started at our institute, or we are coordinating it. And together in the project are participating countries from mainly Eastern and South Europe and some Asian countries. And yesterday we published a spotlight on this on our page, so please have a look. It is also striving to assess the burden of COVID-19 and harmonize the methodology in those countries. Thank you. So all the credits come to my colleagues who helped with the study. Thank you very much.
Yeah, perfect. Thanks a lot, Elena, for this very nice overview. We have some time for questions, and I see that in the chat we already have 3 people who asked a question. The first one is from Romana Hanif from Santé Publique France. Indeed referring to the fact that what is very special about your data is that you have specific breakdowns by severity level in your case data. But she's wondering what if data on symptoms are not available to distinguish mild and moderate cases? Would that be then a motivation to combine these 2 categories, or which disability weights could be used in that case? So I think in general, the question is, what if in my specific country we don't have this data to distinguish severity levels? Thank you.
Yes, I think it makes sense to combine the mild and moderate categories. This is also written in our protocol for the burden of disease assessment from the cost action. There is no differentiation between mild and moderate cases there. So basically this would also work. This shouldn't stop you from trying to do some assessments, yes.
Okay, and I think an alternative could be to use maybe the ratio of mild versus moderate that would come from the German study and assume
This
that
could
this
be
could
applied if the assumption is that it is very much comparable with other countries. Yes, this is also possible.
Yeah. Okay, then I see a next question from Janita Haaksma from the Netherlands, referring to socioeconomic status. So she's wondering if in the German study it would also be possible to look at the burden by socioeconomic status, because we all know that there are always important differences both in incidence, death rates, severity across socioeconomic status.
Yes, this is a very interesting point. Basically, in our project, we are intending to use the deprivation index developed at our institute and apply it to the burden of disease assessments. We haven't been so far yet because we are not ready with all our estimates, but this is basically the next step that we want to do. And definitely for the COVID cases would be also very interesting to see all these differences. But we haven't done it yet. But very nice idea. We can do it.
Yeah. Okay, thanks. And then maybe a final question from Lorenzo Manasta from Italy. He is referring to the recent estimates of IHME of excess mortality by country, and I just saw passing by that today WHO also launched estimates of excess mortality. So he's saying that most probably the deaths in Germany were underestimated. Also the non-fatal cases. So how was this aspect of underestimation or undercounting taken into account in your analysis?
We are basically very critical to the IHME assessments because for Germany they estimate about 35,000 more deaths than observed till now. Like we have 1/3 more than what is reported, and this is yes, very critically discussed at our institute because we basically don't agree with this assessment. We don't know where it comes from, that so many excess mortality is estimated from COVID, and we are not really, it is not really clear the methodology that they are using. So basically, we don't agree with this assessment. I have no idea what WHO has published yet. but we tend to believe that the registration system in Germany is pretty good. So there shouldn't be so much over or underestimation of these cases.
Yeah, thanks. But in any case, it's always a point to be very cautious about and to be, to understand that this may, of course, be the case and can have an impact on burden estimates.
Yes.
Okay, so maybe for the interest of time, I would suggest we continue with the second presentation. So I want to thank Elena once again for presenting us the initial estimates of COVID disease burden in Germany. And in our next presentation, we will have Grant Wiper from Public Health Scotland, who will be presenting us the COVID burden estimates for Scotland. So Grant, feel free to take the floor.
Okay, thank you, Greg. I'll just try and share the PowerPoint just now.
Yeah. Yeah, perfect.
Do you see that okay? Yeah?
Yeah, thanks.
Okay. Hi, I'm Grant Wiper, a Public Health Intelligence Advisor from Public Health Scotland. And first of all, many thanks for the invitation from both the unCoVer and the Burden EU networks to share our work relating to COVID-19 burden of disease assessment in Scotland. Today, I'll give an overview of our journey from the planning to dissemination stages of our work, in which we assess the impact of COVID-19 using disability adjusted life years during 2020 in Scotland. So in Scotland, we already carry out the Scottish Burden of Disease study, and in this study, we estimate DALYs for over 100 causes of disease and injury at the national, regional, and local area levels. And this is carried out to assess the contribution of how causes of disease and injury are preventing the Scottish, national, and its local populations from living longer lives and better health. Since the emergence of COVID-19, we've been undertaking work to integrate COVID-19 into the cause list within the SPOD study, as well as needing to do this to ensure the SPOD study remains a comprehensive assessment. There are other key benefits realised through doing this. Calculating DALYs due to COVID can also enable us to undertake comparable future assessments of the direct and wider indirect pandemic harms. Our main study aims were to estimate DALYs due to COVID-19 as a cause of disease during the first calendar year. Secondly, to frame these DALYs relative to pre-pandemic causes of disease and injury. And our final aim is to assess socioeconomic inequalities in COVID-19 DALYs. We've undertaken and we'll cover the first two study aims today, and we've almost completed our work on socioeconomic inequalities in COVID-19 DALYs and should be reporting these findings very soon. So in terms of methodology, we set up to remain consistent with our core SPOD study. And so this really means that we're assessing outcome-based DALYs, which for COVID-19 include the acute stages with some related post-acute consequences, which wouldn't otherwise be captured through other parts of our disease cause list. COVID-19 was treated similarly to all other conditions in terms of data use, although we clearly have much stronger and readily available infection data than ever before. In Scotland, we have a very up-to-date death registration system, which meant that we could utilise cause of death information for our calculations. And we used a sensitivity based on COVID-19 as the main cause of death, which would represent the usual approach to a burden of disease mortality assessment. And we also use COVID-19 as any cause of death for an upper limit for DALYs. The methodology which we used to calculate DALYs was based on that which was developed within the European Burden of Disease Network. And we used the Global Burden of Disease 2019 life table for calculations of years of life lost due to premature mortality, which is again consistent with the methods from the core SWOD study. Our data inputs for morbidity came from a mixture of transmission model estimates and daily data, which were reported on the number of cases overall and cases requiring hospitalisation, and that's both those requiring with or without intensive care. As we had availability of daily data since the first case, we were able to avoid assumptions over duration, as YLD was calculated on a daily basis. We've since worked out that this approximately means that durations were roughly about 8 days for all cases, and when just looking at hospitalised cases, we're looking at roughly a duration of just over 2 weeks. As previously stated, we had access to the provisional cause of death estimates based on date of death, and this was available with just a few weeks lag time. The mortality data is highly credible, and it's unlikely to change when causes of death are finalised, as the main changes occur from external causes of death, such as suicides or drug-related deaths. Just again to stress that we've treated this exactly consistently with how mortality is estimated in the core SWOD study for all other causes. We've looked to disseminate our methods through the European Burden of Disease network with partners, and within Scotland promote the use of DALYs using social media and through infographics on our web pages. DALYs are highly technical, involve many data inputs, so they aren't easy to understand when they're just taken off the shelf. And it's important to offer content across different points of the spectrum to meet the needs of different users and to capture new audiences. Only pointing to journal papers and appendices is not always ideal, particularly given the scale of attention on COVID-19 due to the increased, I guess, relevance of people that wouldn't normally access health or public health data. In Scotland, this is involved is trying to present plain English accounts of how different individuals' experience would translate into DALY calculations. And our main example of this is the infographic on the slide. In future, we plan to adapt these sorts of infographics to include examples of how indirect and other pandemic harms could emerge to try and aid people's understanding. Our main study findings were as follows. There were around 1,800 to 2,000 DALYs per 100,000 population due to COVID-19 in Scotland in 2020. And we found that there were estimated to be just over 15 YLL for each death that had occurred in Scotland. And of all the infection health states, the post-acute consequences were the largest contributor to YLD, and this was followed by community-based infections, though it must be noted that the transition probabilities for post-acute consequences were sparse, and I guess there's a lot of uncertainty around them. However, in terms of the DALY estimates, the overall contribution of YLD was minimal, very similar to the German study, although very different methods. Approximately 98% of all Scottish COVID-19 DALYs were from mortality. Furthermore, we compared the number of DALYs due to the 15 pre-pandemic leading causes. We found that our estimated range of COVID-19 DALYs was likely to have represented the second leading cause of disease and injury in Scotland. And this is a result that was confirmed across lots of scenario analyses which we performed. And these were really designed to try and address any potential undercount in community-based infections, which we felt was the largest area of uncertainty, and also scenarios which halved and doubled transition and duration probabilities of post-acute consequences. We also triangulated with GBD data for the leading causes of burden. Across all these scenario analysis, our results were consistent given the fact that the contribution of YLD is relatively low, and I guess as part of overall DALYs. We also looked at how our results may have been impacted due to COVID-19 during 2020 as a competing cause of death on other cause-specific mortality. Of note, we only found that respiratory deaths had large decreases, and the changes in other causes such as cardiovascular or Alzheimer's were much smaller, and on the whole, none of these were likely to impact any of our conclusions. So in conclusion, COVID-19 has had a devastating direct impact in Scotland. It went from a single case in early spring 2020 to be estimated to be the second leading cause of disease in the same year. In all of our findings, we expect a high proportion of these DALYs would be attributable to prior risk factors. And this is something that will be touched upon more in our analysis by socioeconomic status, given how prior risks and morbidity and mortality outcomes are already socially patterned and affect those in the most deprived areas the most. I feel our results highlight the need for a healthier society with reduced vulnerability as a means of achieving DALY reduction for COVID-19 and any other potential future epidemics or disasters. And in Scotland, we'll continue to monitor COVID-19 within the SPOD study, as well as all other health conditions, to try and estimate the contribution of diseases and injuries and risks on the population health of Scotland. I have some learning which I believe will be transferable to those undertaking COVID DALY studies, and they're also important discussion points when thinking about COVID-19 DALYs. Particularly the continued estimation into 2021 should hopefully indicate the extent of positive impact through DALYs averted due to vaccination rollouts and continued mitigation efforts. I guess tying the presentation which Elena had done and our own together, it's really important to give proportionate focus on the impact of mortality in these estimates. YLL is a really close proxy for DALYs, so scrutiny over comparability of mortality approaches is a factor of leading importance. Of course, the method choices which we make for YLD are also very important, but in terms of the DALYs, it scales towards the YLL. Continued monitoring of these DALYs gives us good opportunities to monitor the weighted impact of the pandemic, as doing so will allow us to capture DALYs due to several mechanisms, and these could appear such as those due to COVID-19 infection, the post-acute, both clinically related harms and those harms which are as a result of increased vulnerability following infection, and also the indirect harms which are due to other pandemic-related restrictions to vital services and such things. Finally, I'd like to acknowledge the contribution of the other individuals that contributed to our Scottish assessment, whom I've listed on this slide. And many thanks for listening. I hope that our work in Scotland's been informative for you. As I mentioned before, we're currently in the process of finalising our analysis and reporting of the impact of COVID-19 by socioeconomic status, and this should be available over the coming month. If you're interested in these results, please keep an eye on our web pages and our Twitter feeds, and I believe these slides are already on the Burden EU website, so I've included some links and further information if you'd like to keep up to date with the SPOD study, and also we have a list of published COVID-19 DALY studies on the Burden EU website, which is also very interesting if you're embarking on your own studies. Thank you.
Yeah, perfect. Thanks a lot, Grant. We again have some time for questions, and I see in the chat that there have been quite some discussion going on related to the underestimation, both for the mortality, but also the cases. So could you maybe explain a bit what the aspect of underestimation was in the Scottish study and how you dealt with that?
Okay, so yeah, so in terms of the Scottish study, so I'll deal with morbidity first. So we undertook some scenario analysis to increase the community-based infections by a fixed proportion. So that varied between sort of 10%, 25%, and 50%. And what we were really trying to highlight was that no matter how in the most extreme situations, that if we underestimate the cases, the DALYs don't change because of the relatively small impact of YLD. And although it's obviously we're trying to get the best estimate we can, but much of our aim was really around the general framing of COVID as a health issue. In terms of the mortality, if that was an underestimate or not, well, we used looking really to integrate COVID into our Scottish study. So we sought to treat COVID as we treated all other conditions. So I guess from the perspective of any underestimate, using the sort of cause information we felt gave us a good lower limit, and using the sort of COVID as any cause of death gave us a good upper limit too.
Okay, thanks, Grant. Looking at the chat, so if there would be any further questions for Grant, then don't hesitate to write them in the chat, or maybe directly ask them to Grant by unmuting yourself. Maybe one general question that I had, both for you and Elena. So we see in both studies and also in other studies that the mortality component is dominating the DALY estimate. So do you have any further reflections on that, on what that might mean for interpretation and use of these estimates, or communication? How do we communicate about this towards the many people with a non-fatal COVID infection, of course? Grant, maybe?
I could take that one, yeah. So I guess from the Scottish perspective, obviously this isn't something that's new, and the vaccination strategies are really geared towards mortality. I think obviously not to underplay the sort of spread of infection as a means for increased mortality. Obviously, we want to stop the spread, and it's a big international issue. But I think just going back to our aims, there's lots of conditions out there which are highly prevalent, and people might think are not debilitating, like headaches or things like that. So I think just looking through things as a broad lens gives us that alternative way of scaling health issues. And I think particularly with the increased focus that many people have on COVID and interest in health, we've got a real opportunity for DALYs and helping aiding people's understanding of the scale of health issues and health inequalities that existed before COVID.
Yeah, thanks. Elena, do you have any further reflections on that?
Yes, in terms of the mortality, because of COVID, I think there are a lot of issues that at the moment the federal states are working on, like improving data quality and data registering and multi-causal statistics. So it sounds a little bit bad, but we somehow profit from such a thing that in long term the data quality will be much improved and better registered. And in terms of burden of disease, I think mortality is quite an issue, but we shouldn't forget the long-term effect of COVID, and we should concentrate on quantifying this because it is not an issue that we can neglect.
Yeah, indeed, thanks. So I think indeed, even though for the sake of the DALI calculation per se, it would be maybe even sufficient to focus on the mortality aspect, but we shouldn't forget that even a low YLD estimates can still reflect a very large number of people, and that it's important that we can acknowledge these people and the existence of these people, and especially then, as you rightly mentioned, in the context of long COVID. So with that, I would like to make the bridge towards the last speaker. And the last speaker will be Dr. Joe Breen from the National Institute of Allergy and Infectious Diseases in the USA. And Dr. Breen will be presenting us some insights and future perspectives on post-COVID conditions with a main focus on immunological studies funded through their institute. So thanks a lot, Dr. Breen. Welcome, and please feel free to take the floor.
Thank you. Brecht, can you see my presentation?
Yeah, it's perfect, full screen. Perfect.
Great.
Thanks.
So that was actually a really nice segue. So thank you to the previous speakers. And before I start, I want to thank Brecht and Sarah and the networks and organizers for inviting me to come talk to you today. I work in the National Institute of Allergy and Infectious Diseases, where I manage a number of grants and contract programs in the area of basic immunology. And as you might expect, over the last year and a half, we've been focused not exclusively, but certainly to a very great extent on COVID. And I'm going to talk a little bit about COVID conditions and then more about post-COVID. So actually it is a bridge from much of what you've heard. I don't have as much epidemiological data, but I think I'm going to show you where that will be generated for a gap that exists and was highlighted a little bit in the question and answer session. So my talk is really post-COVID conditions, what immunology studies we have underway, and then where some studies are going to try and address some of these issues. So really three topics. The first is some longitudinal studies that were originally actually, one of them was initiated for COVID proper, but has transitioned to try and understand the mechanistic studies and effects that go along with post-COVID conditions like long COVID and other similar conditions. And then I'm going to talk about the NIH program to study specifically the post-acute sequelae of COVID, the PASC program, which encompasses long COVID as well as childhood conditions and frank pediatrics, and then a little bit about perspective at the end. So this is probably redundant, but our institute is very centered on mechanism of what is causing this disease, and really, of course, post-viral phenomena overall, and how does disease correlate to initial disease, viral and host genetics, host immune response to infection, and more recently in the last year, response to vaccination, which actually there is some pretty interesting data about post-COVID conditions and vaccination. And then, of course, therapeutics and vaccine and how that affects outcome, which earlier speakers also addressed. So the first study I want to tell you about is a large study that was that began last spring to try and understand at a mechanistic level what was happening with COVID patients. And this study was planned for severe patients that had to be enrolled, essentially. So they're adults that were enrolled in a number of hospitals across the country, across the US. And it was designed to recruit between 1,000 and 2,000 hospitalized patients, and ultimately enrolled 1,200 and is now following them prospectively. They'd done a clinical assessment inpatient, and then upon discharge, will bring patients back. Or in some cases, as we've found out, to make this work, we had to come up with a visiting nurse type system to go to visit people to get samples that I'll show you on the next slide. But the practicality was actually very challenging. We probably should have realized, severe patients, you know, once they get out of the hospital, they'd kind of like to put that into their past if they can. Whereas, you know, mild and asymptomatic, of course, it might be a different situation. But in any case, the patients are enrolled, and now we're following them and starting to do some of the immunological studies. And also, you know, with 1,200 patients, we will get some idea of the different burden of disease. So what are we learning? So the inpatient part has, in the clinical piece, has detailed history, radiology, over time harmonized with the ISARC and case report forms. And there's also, since this has been done, case report forms developed for long COVID, actually, and other post-COVID syndromes. And then importantly, in the outpatient phase, assessment of functional recovery and other patient-reported outcomes, such as fatigue and some of the neurological complications and cardiovascular complications, which are very common. They're common in a severe hospitalized population, but also in a SARS-CoV-2 infected population. And that's where we may actually then be able to measure things that are really of a post-viral phenomenon that will differentiate it from ARDS, for example, and other severe phenomena that occur post any hospital visit. The all time points in terms of the mechanistic studies provide whole blood, serum, plasma, white blood cells, nasal swabs, and endotracheal aspirates, if intubated, of course. So we hope to generate a tremendous amount of information mechanistically about what's happening and certainly in the clinical as well as the outpatient portions, to try and understand really what's happening and how much of the disease itself is related to some of the factors that I mentioned earlier, as well as now we're learning the post-COVID phenomena, you know, what is the burden of disease and why some are suffering continually and others recover. And again, one limitation here is that this is a hospitalized population. So the next section of the talk is the Post-Acute Sequelae initiative at NIH. In January, the US government appropriated funds to study this post-acute sequelae phenomena, which again includes certainly long COVID, but some other, it's a very inclusive program as an initiative. There were 2 announcements, and there is more information available at this website, which I have included here, that people could look up if they're interested. And it's a developing program, I should say. So what is this program? It's really to understand really the ability to treat the post-acute sequelae. And that starts with understanding what are the clinical spectrum of disease from acute infection over time. And there is a few ways that that's going to be done. And for those patients who don't recover, what is their incidence and prevalence, natural history, clinical spectrum, underlying biology and phenotyping. And does just more about the post-COVID condition and what other complications may be. How will this be done? The idea is to generate a large clinical cohort study that would be across the country, and also does allow for international collaboration and input, and really work together to do this and with a common protocol to really understand the depth of the problem. I think Elena mentioned, we don't really know. There have been various case reports estimating anywhere from 10 to 30% or even higher of post-COVID sufferers, people who suffer and do not return to their quality of life after COVID infection. There's also an autopsy cohort aspect to this. An electronic health record and other real-world database studies are also planned and were part of the original call for applications that was a few months ago, actually. So while there's a large clinical component, there will also be a clinical science core, a data science core, and a biospecimen repository core. And all these pieces will work together to try and achieve the aims of this award, which are this initiative, which is essentially collect and build a cohort to understand the burden of disease and then what's causing it, of course, and hopefully come up with some interventions while we're working really hard on vaccines and therapeutic interventions right now for acute COVID, of course. So there were two initial research opportunity announcements, and applications for the aspects that I've just described are under review. And there will be development of a collaborative multidisciplinary research consortium to get at, again, the incidence and prevalence to the best extent possible in all the populations that we have. And then again, the mechanistic studies that go along with that. And a big piece of this is because it does involve, long-term post-viral suffering is to engage with key stakeholders, including WHO, the U.S. Center for Disease Control, clinicians who are seeing these patients, and patient community advocates, patients themselves, and caregivers. And we really want to facilitate ongoing collaboration to make this all possible and have knowledge sharing. And once the awards are announced, I think you'll see, and we fully anticipate that there will be input from these stakeholders into this to help really with the whole entire effort. And I'll stop there. This is my contact information. I'm happy to answer any questions. And I should say that, again, that this is not my work. There's many groups that are currently working on this PASC initiative. I'm part of a team that's doing that, and the impact program is as a multi-center award that is from actually initially from my institute and my division, but it's a whole team of folks, and I'm sure you'll be reading more about their output in the preprint and the peer-reviewed literature quite soon. Thanks.
Yeah, thanks to you, Dr. Breen, and we indeed very much look forward to seeing the initial outcomes of these studies. As we've seen with the German and Scottish study, these studies will provide very valuable information for our burden of disease studies, with initial scenario analysis already indicating that at least half or even the majority of the non-fatal burden of COVID could be linked to post-COVID conditions. So indeed extremely crucial for us. I see that we already have some questions in the chat. First one from Dr. Joan Soriano, who's now working at WHO, supporting them in the COVID response. Maybe Joan, if you're okay, you can ask your question directly to Dr. Breen. That would be possible.
Sure, Brecht. Good morning to everyone. First, congratulating the session, which was excellent, and there were 3 great presentations. 2 quick questions, but I probably already have the answer. IMPACT could be the first true natural history study from infection of SARS-CoV-2 to healing, and even including 1 year of follow-up of patients with PASC. Are there any preprints or publications already that we can quote?
I believe the clinical protocol was published, and I apologize I didn't put that in my presentation, but I think that is what's available to date, but not true results yet. I think they're still collecting, to be honest.
Right. And the second thing is more pragmatic. The Biden administration committed $1.1 billion for PASC. Do you have any hint or any suggestion if we could apply from Europe to part, not all, but just part of this budget?
Well, the initial rows were open to international applicants, certainly. So I don't anticipate that changing. I guess it depends on. I mean, I thought your question was going in a slightly different direction. So that, you know, that there was $1.15 billion allocated, and there is a hope, of course, that we'll reach therapeutics, which are not part of the initial call. So I think there's more to come from this initiative, which it's fair to say. And again, they're not awarded yet, so I can't say where those centers and who is going to be awarded, but I can tell you that it was open to international, the 2 initial opportunity announcements.
Well, thank you, and I strongly urge Jose Luis and Brecht to apply to part of this budget in due course. Thank you.
Yep.
Thanks a lot, Joan. I see Jose also had a question on the PASC initiative. Maybe Jose, you can.
Yeah, thanks, Dr. Breen and Elena and Grant on very nice presentations. Just a very short question, also because unCoVer is dealing with electronic health records, and we are very interested on also pursuing further studies on post-COVID. How do you see the advantage of this type of data versus, for example, the clinical cohort that you have already within the PASC study, how they can complement each other?
I think the attributes of the EHR will probably overlap but not be the same. And the other issue is the populations may actually be different. You know, we have underrepresented but overrepresented in terms of disease populations in the US. And so that will be, that may be more straightforward in the EHR type study. I'm thinking of the tribal areas, for example, or the other opportunity is that the cohort studies may have the opportunity to enroll and collect samples and do some in-depth analysis that we wouldn't really get from the EHR. So I think they're going to be complementary.
Thank you. Thank you so much again.
Okay, thanks. I see we've reached the end of our webinar. I also don't see any specific further questions. So yeah, with that, I want to thank you all for participating, and a special word of thanks to the 3 presenters and to everyone who was involved in the organization of this webinar. As mentioned, we will make the presentations and the recording of the webinar available to everyone for reviewing after this session. Yeah, so if you want to stay informed about the activities of the Burden of Disease Network, feel free to have a look at our website. We also have a specific Burden of COVID working group, which is led by Sarah Pires. So if you want to stay involved in the proactive discussions on these aspects, please feel free to reach out to Sarah and to join these working groups and these discussions. Maybe I want to give the final word to Jose or David. Thank you.
Yeah, from my side, just thank the speakers again. Thanks, Brecht and Sarah and the other members of the European Burden for inviting unCoVer to be in this first webinar that we are co-organizing. And as Rex said, if you have any questions, you have the webpage of unCoVer in the presentation. Let us know how we can collaborate or how can we discuss further. Thank you.
Thanks a lot and have a very nice day, everyone.
Thank you.
Thank you. Bye.
Thank you. Bye.
Thank you.
Thanks.